Good afternoon, everyone. Welcome to HNF webinar series. So today we're expecting a big crowd, about 300 to 400 people have signed up. But I don't think we should wait for everybody to come on board to the Zoom meeting. And today our CEO, Dr. Christina Tiong, is not available, so I shall have to do the honor of introducing HNF and also this webinar series. So Home Nursing Foundation, as everybody know, it has been established in the 70s by the then Minister for Health, Dr. Toh Chin Chye. And at that time, of course, when we started, it was mostly maternal and child health in the villages and kampongs in Singapore. But as Singapore aged, economically and socially developed, like all societies, the population ages, and we know now HNF is one of the largest home care provider that provides home nursing, home medical, home personal care services, as well as home therapy services to homebound seniors. And not just that, long-term care aside, the whole nation is in the direction of healthier aging, and so we have also embarked on the development of Active Aging Center. We have currently one in Buangkok, but another one in development. And we have got two senior care centers as well in Hougang and in Buangkok. So we look forward to working with all of you as our partners in the transformation of the sector, in the development of the regionalized integration of care. This webinar is also our offering to sort of our contribution to further the professional development of our sector. So just a word on why this webinar was mooted. It was about 2 years ago in 2023, sometime in April. There was a thought that the community home care physicians, sometimes they do not have professional education catered to the special circumstances that they work under. So as a visiting doctors, we see a lot of homebound seniors and stressed out caregivers, and they are it's no longer just disease management, although those are still very important. It's really whole person care. And as a doctor, we need to learn more about setting goals, realistic goals, and also meaningful goals together with the patient and the caregivers, and also various elements of palliative care, mental health, even social determinants of health. All these are really important. So in the 2 years, we have covered topics related to palliative medicine, renal medicine in old age. We have covered psychogeriatrics. Recently, Dr. Sin Guen Lee covered mood disorders common in seniors, as well as common psychotropic drugs. And dementia medicine itself, we have Dr. Philip Yap about 1 year ago when he shared with us his experience in caring for people with dementia. We've got Dr. Lee Keng Hock talking about social prescribing. We have also a series on InterRise. So all these are can be found in our YouTube channel. Thanks to the generosity of our distinguished speakers for us to record. And the idea is there are many home care physicians who are locums in not just in HNF, but in many other places. They don't have time to attend CME. So if they tune into the YouTube channel, they can also obtain CME points. So that is our offering to all of you. So today, we have a very special guest with us. You can see on the screen, Ms. Zelia Kwa. Let me just give a brief introduction of Ms. Kwa. She's a clinical psychologist who runs her own practice. She graduated from the University of Queensland, and she helps in the community supporting psychiatrists, neurologists, and GPs in specializing in geriatric psychology, helping seniors with cognitive impairment and mood disorders. So when I heard Dr. Christina Tiong introducing Zalia to us, I was really quite excited because this is a very common problem. Seniors, they have got long lists of medicines we all know, and all of them interact with each other and run the risk of complications. And many a times, it increase the frailty and decrease the functionality of the seniors. So in community geriatrics, we try not to add on medications if we don't have to. So it's very important for us doctors to learn about non-pharmacological approach. So today our topic is healthy coping skills, non-pharmacological interventions to manage mood disorders and insomnia. So, which is very common, I'm sure all of you in the community, whether you're in nursing homes or you're home care physicians or visiting home nurse or even social workers, you must have encountered patients like that, and also their caregivers. And yeah, and you can't just prescribe away insomnia and mood disorder. Sometimes you can do that, but we know antidepressant is only effective 50% of the time. The efficacy improves if you add on CBT or some kind of counseling to the mix of the therapeutic options. So how we like to conduct this is this. I will be presenting a case of mine, which is a very senior gentleman with both some kind of low mood. I didn't diagnose depression, and with insomnia. So I like to, and then Zalia will give us a lecture. It's a generic lecture related to mood and sleep disorders in seniors, but we'll take reference with the case I present, and we'll have a discussions at the end of it. And I also encourage all of you to post questions if you have on the Q&A section of this particular Zoom meeting. So let me just share the case. Okay, I was called to see this gentleman in November 2023. He's 88 years old. He was 87 then, so now he should be around 88, coming to 89. Chinese gentleman with low mood and insomnia. So he does look like this, but I got this picture from the internet under Creative Commons. So he's an ex-Chinese teacher. His house has a lot of books, and yeah, he's like a Chinese gentleman. So 2 sons and a daughter, lives with the elder sons and his family. I've not seen the whole family, and I don't usually do a whole genogram unless I have to. The family is very supportive. So lives with the son, the wife of the son, and then there's a daughter who's the main caregiver, lives in Malaysia, who I communicate with. And the wife has severe dementia, and they've got 2 helpers at home in the landed property. So he enjoys food and he enjoys driving around town. So this is his past history. He's got a CKD, quite chronic. Baseline is about 28 to 30. And he's got impaired glucose tolerance on dapagliflozin for many years, and hypertension and BPH with TRP. But why was I called? Sometime in 2023, he had a lot of admissions. So in June, there was a common bile duct blockage with sepsis and was admitted to the hospital for ERCP with the removal of the gallstone, and also incidental diagnosis of paroxysmal AF. And soon after discharge, he got in for elective cholecystectomy, but developed pneumonia in the ward. And because of the AF, they started apixaban, and he developed allergic reaction to the apixaban. And somehow there was a drastic drop in HB, and they suspected upper GI bleed, but he refused OGD. So he was on apixaban, and so those were all stopped. And he was also on aspirin, then that was stopped and changed to clopidogrel. And in October the same year, after return from home, he had acute gastroenteritis with septic shock. And in November, the family called me in crisis. The father had a asymmetrical face, okay, with a drooping lid, with a drooping lid and slurred speech. So I told them you should go to the hospital because it sounds like a stroke. But they say, can we not go to hospital? So when I saw him, um, he had slurred speech, lower face asymmetry, and he said he didn't want to go to hospital. So I called up a few neurologists. None of them want to manage him in the outpatient. One of them told me, you have to admit him to the hospital. So I told the family, I'm really sorry, I can't manage this as an outpatient, even though, as a home care physician, you try to respect the family's wishes because based on, all the various factors, at play. But I suppose there was some rapport, and I've tried my best to communicate with the neurologist, and he gave in, and then he went to a private hospital on the same day. And at that time, when I saw him, he was on those medicines listed down there: thyroxine, ezetimibe, valsartan, clopidogrel, allopurinol, bisoprolol. Is on a phosphate binder, and simvastatin, omeprazole, and dutasteride. And well, because there was, when I saw him for the first time, he just didn't want to go to hospital. So I had to do a full assessment before I send him to the emergency department or decide what to do next. So I did the rest. At that time when I saw him, his CFS level was 6. So that means he's not independent in BADL. So he was diapered because of frequent urination. He was still able to walk, but he needed help in showers. And when he walked, he needed contact guard because he was very frail. He lost a lot of weight after hospitalization. So the family didn't allow him to walk without any aid. So they had some contact guard. Not able to climb stairs. He lives in a double-story house. So he stayed downstairs from his own bedroom, in a what looks like a study in that house. And he was housebound then. And there was some difficulty chewing because his dental implants had fallen off. Prior to these bouts of hospitalization, that means before June 2023, he was driving around, meeting his friends for food, independent in IDL. So he was CFS 4, becoming CFS 6 after a series of unfortunate events. There was no cognitive impairment at all. There was low mood. He was frustrated, demoralized because of the repeated admissions, lying in bed, and restricted in movements. The family was particularly concerned because he was very down. He's not his usual self. I didn't do a geriatric depression scale because I felt it wasn't really needed. It was very obvious to me. And the systems review showed that there was a drastic loss of 7 kg over 6 months throughout the septic shocks, the hepatobiliary sepsis, and the surgery, right? And the allergic reaction. The vision and hearing was okay. He had poor sleep with nocturia. So at that time, my thought was, could this be a depression causing poor sleep? But when I took a history, actually, he had poor sleep since his 50s. Okay, so it was not due to the current state of depression. And he thought a lot of old days, and he did have some existential crisis, like purpose of living and when he's frail. There was some pain, 4/10 at the calf and 5/10 at the back. So of course, all this can contribute to insomnia as well. Skin was okay and a bit of cough. There are many appointments, and the vital signs were all stable. No postural drop. There was a left pronator drift, left lower face droop, and there's a dysarthria. So very likely it is somewhere in the right brain, maybe at the thalamic area, right? So dysarthria and dysphagia on thin fluids, and then abdomen was soft and PR was empty. So my diagnosis was there's a new stroke, probably infarct because there's AF, right? Embolic stroke, and there's dysthymia. I can't quite say it's depression because there were so many of these event, so it's quite understandable that he should be demoralized. But if it does impact too much, I would also start antidepressant. But I diagnosed as a adjustment reaction, and because I'm going to admit him to the hospital, I didn't initiate any treatment. Poor sleep, it was long-standing since the 50s. Since he was in his 50s, he's now nearly 90. Yeah? And there was nocturia, partially contributed by BPH, partially contributed by poor sleep. And there's some pain. It was most likely musculoskeletal because of the places of the pain. Okay. So I like to leave this case for Zelia to comment as she present on her presentation on managing low mood and insomnia in a senior. Zelia.
All right, thank you, Dr. Ng. Thanks for giving me a complicated case to work with.
We can work on it together, no problem.
Yes,
Yeah.
all right. Yeah, and this is often the reality as well. It helps to work in a multidisciplinary team,
Yes.
to brainstorm and see the different holistic aspects of a case.
Mm.
Okay, so good afternoon, everyone. My name is Zelia, and today I'll be presenting on the different non-pharmacological interventions that allied healthcare professionals or nursing staff, or even sometimes physicians as well, can apply or recommend to your patients to manage their mood disorders and insomnia. So, before I came out to private practice, I was working in Changi General Hospital for almost 8 years. So I've had a lot of experience working in the community setting also, because we partner with community care agencies and also nursing homes to manage some of their patients as well. And as you know, a lot of patients end up in the hospital. So it's nice that there is a kind of a transition when we know patients and we follow them through the journey. Yeah. So currently, I see patients privately at my practice called Cerebral Heart Psychology. Yeah.
Mm.
So, okay. So, I actually recently saw this commentary on Channel News Asia that has a big headline that says that seniors are suffering in silence. So the commentary was about how a lot of older people are feeling old, feeling useless, but yet their mental health challenges are not really detected by people around them or even by healthcare professionals as well. And there a lot of them are actually suffering in silence. At the same time, a lot of them are suffering in silence because compared to younger cohorts, some NUS researchers have found that Singapore seniors are less likely to seek help for their mental health. And it is really important for us to ensure that we are able to implement early detection so that no senior is being left behind per se. So why is it that these seniors are so reluctant, right, to seek psychological support or even telling people about their mental health challenges? So some of the reasons include having to step out of their comfort zone. So there's actually so many activities available in the community. As Dr. Ng has said, there are a lot of active aging centers available, and we really want to encourage older adults to participate in them because we know that social participation in activities can improve mood, but some find that it is stepping out of their comfort zone. Some find that the activity is overwhelming or that they might have to travel to unfamiliar locations that can lead to more disorientation and stress. So some of the seniors might also refuse psychiatric medications out of fear of cost or side effects, or they can feel very self-conscious talking about these topics with a stranger like a therapist. Yeah. There's also issues of social isolation, fear of failures, and also low mental health literacy among the older adults that put them at higher risk of poor mental health problems. So even in the Healthier SG initiative, I think we used to focus a lot on physical health. Now, especially after COVID, the government has also placed more emphasis on mental health. And not only in the younger populations, but we also want to take note of them happening in the older adults that we see too. Okay, so I was interested to find out more about what the prevalence of depression was like in Singapore. And there was a there was a study that is done by the Institute of Mental Health, IMH, which is called the Wellbeing of Singapore Elderly Study. So this is quite a large-scale study where they have followed up older adults over many years, and they found that in 2013, there were about 3.7% of Singaporean elderly that had depression. So that means you imagine every 27 older adults that you see, right? One might already have clinically diagnosed depression. And in 2023, 10 years later, this number increased to 4.4%. So that was about 1 in 23 of older adults. So then you might think, okay, this percentage doesn't seem very high because these are all clinically diagnosed depression. But for those older adults who meet one or more symptoms that we call subsyndromal depression, the rates is actually higher, almost 13.4%. That means 1 out of every 10 seniors that you see, 1 in them might have some kind of symptoms of depression. So we're trying to say that this is a really prevalent issue among older adults that we see. Okay. And in the Singapore Chinese study, we found that if we are looking at the age group from 60 to 95, actually those between the ages of around 75 years old, had the highest risk of depression compared to their younger and older peers. And the researchers provided the explanation that perhaps it's because younger seniors, most of them are still mobile, they have more resources, so they're able to, garner these resources to help them cope with their depressive symptoms. Whereas those of the, later life, they are more at peace with their stage of life already, where they're at. So they may not experience as much depressive mood or severity of symptoms as those within the 70 to 80 age group. Yeah. Okay, so since it's so important for us to be able to identify depression, because sometimes the older adults might not be revealing to it ourselves, the next thing I want to share with you is about the criteria of a major depressive disorder. So it doesn't mean that just because someone feels sad that they have depression. The individual would need to meet 5 or more of these symptoms over 2 weeks of duration, with at least symptom 1 or 2 present almost nearly every day to qualify as depression. So symptom 1 is low mood, and symptom 2 is a loss of interest in activities that they usually like to do. For instance, let's say Madam Tan, she usually likes to sing karaoke, but then you notice that in the past 2 weeks, she hasn't been coming down to your center to participate in karaoke. So then we want to investigate whether there's this loss of interest in usual activities that they like to engage in. So in order to have depression, 1 or 2 must be present nearly every day. And then there could be another 4 or more of these symptoms, including suicidal ideation, recurring thoughts of death, feeling ashamed or guilt about themselves. Maybe they might say things like, I'm such a burden to other people, I'm troubling my children. There's sleep that's being affected, so it could be insomnia, which is a loss of sleep, or also hypersomnia, which is sleeping too much as well. We might also see psychomotor retardation, appetite changes, loss of concentration, energy loss, and all these symptoms should be affecting their social and occupational function. So if they are working, these symptoms are affecting their ability to work, or if they're just engaging in normal social activities, then these symptoms would must have affected their ability to socialize, for example. So these are the criteria for meeting a major depressive disorder. Of course, we are not expecting people who are not of psychiatric or psychological background to diagnose this. So usually in a more nursing home or community care setting, our nursing staff or allied health professionals can also implement other skills like the GDS. Sorry, I'm missing an S here. But Dr. Ng also mentioned the GDS-15, which is a very valid and reliable tool to assess for depression. So all these symptoms here you see would be quite similar and also map onto the DSM criteria that I was mentioning earlier. Yeah. Okay, so I also wanted to talk a little bit more about the risk factors of depression so that you can have an idea of who are the older adults that might be more at risk and paying more attention to them. So the demographics include being male, being unemployed, and having below primary education. Usually, there might be physical function or physical health being impaired or affected, like having poor physical function, not being able to do a lot of ADLs themselves, so having instrumental limitations like not being able to take public transport, not being able to plan their finances. Pain is also a high risk for depression, as well as the presence of major chronic diseases, cognitive impairment, and poor sleep quality. So we can see, no wonder that Dr. Ng's patient was, at very high risk of having depression, even though Dr. Ng might not have diagnosed it, but actually it is trending in that direction already. So he met some of the demographics here. I mean, we don't know his education level, but certainly a lot of the health stresses that the patient had been undergoing would put him at elevated risk of depression. So if in our work we also notice that the older adult is living alone, not being able to participate in activities or lacking in social support, this kind of limited social support and interactions can also increase their risk of depression. Yeah. Okay, so earlier on I was talking about the geriatric depression skill that can be implemented quite quickly in a community setting because it's just a yes or no type of thing to answer. And if they don't speak English, it can be translated as well into Mandarin or other languages. So if the older adult were to score below 5, then it's good. That means their mood is still normal. However, if they're scoring between 5 to 10, then it might be suggestive of depression and would warrant more comprehensive assessment from the physician. And if they're scoring more than 10, then it's quite likely that there is an indication of dementia. So this skill is quite sensitive and also maps onto the DSM that I talked about earlier. And when individuals tend to have low mood, it's quite common for them to also have suicidal thoughts. So I have also included a suicide risk assessment scale here. In Singapore, we like to use a tool scale, the Columbia Suicide Assessment Scale, as well as this SATS Persons Scale. So I kind of included this because I thought the acronym is easier to remember. So this SAT person stands for S for sex, so males are at higher risk. Age, if they are below 20 or above 44. The presence of diagnosed depression, previous suicidal attempt, alcohol abuse, rational thinking loss, social support loss, organized suicidal plan that we can ask, have you thought about how you might do this? Because some people might think, it's better if that I die, or it's better off that I'm dead, but they have no real plans of how they are doing it. So compared to someone who's saying that, okay, I'm going to go to the 13th floor and jump down from there. So that's quite different in assessing suicide risk. If they have no spouse or if they are divorced, separated, widow or single, that is also a risk factor, as well as the presence of sickness. Okay, so we definitely want to look out for those people who are scoring 3 and above on this scale because they require more closer monitoring. Okay, so now moving on to anxiety. So today I'm going to talk about depression, anxiety, and insomnia. So just let me explain about that first. So with anxiety, anxiety is actually a very common emotion, like even when I'm talking right now, I feel a bit anxious because I know I'm talking to quite a large crowd. However, anxiety disorder is different because this anxiety that the person experiences is persistent. That means it is ongoing. Even sometimes before bed, they are also thinking about the worries. When they wake up, they might also be thinking about the worries. It can be excessive and also irrational. Sometimes the fears or worries that they have seems to be disproportionate to the situation that they are undergoing. So I definitely want to mention that this anxiety disorder is different from anxiety. There is a common and normal feeling of worry when dealing with day-to-day stresses. So the problem is sometimes family caregivers cannot distinguish the difference between excessive anxiety and normal anxiety. So they might say that, oh, my mother is old already, she's just worrying too much, right? But we want to assess whether this too much might fall under the category of anxiety disorder, because if it's considered an anxiety disorder, then it allows us to want to intervene earlier. Okay, yeah, so what might be some causes of anxiety disorder? Certainly stressful life events, such as relationship problems, financial hardships, and of course, in the later life, stressful life events would also include medical health problems, right? So the next thing about health concerns, such as having a sick family member, can trigger anxiety. And not only being sick themselves, having a sick family member like a sick spouse can also trigger a lot of anxiety for our patients as well. Having a new diagnosis and not knowing what to do about how to take care of themselves, whether their prognosis is good or not, can also bring about a lot of uncertainties, yeah. So then, if our patients are also having substances, this might also trigger anxiety. So some prescription medicine, we want to think about their side effects as well. Some people ask me whether anxiety is kind of genetic. So there are some studies that show that anxiety may be passed down from parent to child. So there are some components of genetics there as well. However, we also want to consider daily life situations, like whether the person have also undergone any past trauma, be it in the childhood or in past relationships, in the school or in the workplace, that might also contribute to anxiety, as well as any chronic life stresses like family argument and financial stresses that I mentioned. Okay, so insufficient sleep can also be triggering for anxiety. Okay, so now let me talk a little bit more about what happens when a person experiences anxiety. So the thing is, this thing called the caveman brain might be activated. So imagine when we were living in our past, right, in our ancestors, this emotion called anxiety might be triggered when we are confronted by things like tigers and lions, right? So all these things are what we consider threat or danger in our lives. When we experience all this threat or danger, then this caveman brain will be activated, and it leads us to trigger our fight or flight response that we see here. Of course, in modern lives, we are not going to encounter all these threats of animals. However, the modern life threats of job security, for example, daily life stresses, financial problems, relationship problems, can still activate this caveman brain, which leads us to have the experience of a fight or flight response. Okay, and this fight or flight response is important to know, because when this fight or flight response is triggered, that means our sympathetic nervous system is being activated. So a lot of the stress hormones that we feel in daily life can lead to the downflow of the activation of this sympathetic nervous system. So when you see this person on the right, when they are having this fight or flight response, they are going to become more alert, because they are going to be more alert to the danger that is around, that they might be facing. They might also experience increase in breathing. Why? Because the lungs have to pump more oxygen to the relevant parts of our body part. Let's say if we want to run away, right? Then we will have the oxygen to help us to do so. We might also be experiencing accelerated heart rate, because the blood need to pump harder for blood to go to our hands and our legs, also to activate the fight or flight response. Sometimes we might also experience indigestion. Like, sometimes when you feel anxious, you have that feeling of butterflies in your stomach. That is actually something to do with our digestion being inhibited during the fight or flight response. So the bowels actually become looser. And also we have that butterflies feeling in our stomach with the inhibited digestion as well. And another symptom during the fight or flight response is our muscle tensing up, right? In order for us to go about doing this fight or flight response. So we want to recognize that there's a lot of physical changes that is going on when our fight or flight response is being activated. Therefore, when someone is experiencing an anxiety disorder, you can almost imagine them having all these symptoms ongoing for basically all the time when they are awake, right? When they are thinking about their worries, when they are having excessive anxiety, they are going to be in this fight or flight mode. And therefore, someone with an anxiety disorder, and the most common form is a generalized anxiety disorder, where they are going to worry about a variety of different issues. They are going to feel restless. They are going to feel tired because their body is so activated all the time. They also might feel muscle tension and muscle soreness because the body is in that fight or flight mode. And the body is tense all the time. There might be impaired concentration, irritability, as well as difficulty sleeping as well. So we want to take note of some of these symptoms that are happening in our patients to look out for them, and because it might warrant further investigations. Okay. So in order to help you detect anxiety, I want to introduce the geriatric anxiety inventory, which have been very thoroughly investigated as well and thoroughly researched in terms of its validity and reliability. So it includes items like I worry a lot of the time, I find it difficult to make a decision, I often feel jumpy, I find it hard to relax, and so on. So if a person were to kind of go down this list and they agree on 9 or more of these items, then it suggests the presence of clinically significant anxiety. Of course, this list is a little bit long. It's a 20-item scale. So the researchers actually have also come up with a short form, which is called GAI short form. And it includes only 6 of the questions from the list that you saw just now. So if you administer it on your patients and they tell you that they agree on 3 or more of these items, then it also indicates the presence of clinically significant anxiety, which warrants further interventions. Okay. All right, so now let's talk a little bit more about why do we even want to consider psychotherapy, because honestly, I also see a lot of older adults who have psychiatric medications in place to help them manage their conditions. However, if we were to look into the literature, we are seeing that across many different studies, it is really a combination of both psychotherapy and pharmacotherapy that is superior to just one of these therapeutic modalities alone. And I think Dr. Ng has also highlighted that earlier on. If we want to really bring about long-term sustainable benefits in people's symptoms, functioning, and quality of life, then you need to consider an implementation of both psychological techniques as well as the medications. However, there are also some studies that found that psychotherapy alone can be more efficacious than medications in improving the person's quality of life. Why is that so? Because psychotherapy allows us to reframe our thinking, change the way that we think about our condition, and it can lead us to have a more subjective and positive outlook, regardless of the situation that that we are in, leading us to experience a better quality of our life when we are able to see things in a different way. So I also just want to mention that in all the different psychiatric guidelines that are available, we see that psychotherapy is actually recommended for mild levels of depression. However, when we go on to moderate or severe depression, it is usually pharmacotherapy or a combination of both that work best. Okay, so today I do want to spend a little bit of time introducing cognitive behavioral therapy to you. Cognitive behavioral therapy, or in short CBT, is a gold standard intervention to manage depression and anxiety. And what I mean by gold standard, right, means that it is the most effective treatment, most thoroughly researched treatment. That means having the widest evidence based for targeting depression and anxiety symptoms. So therefore, this is the treatment modality that I want to share with you. There are also many other therapeutic modality, and I can talk about that if HNF invite me back next time. But for CBT, we want to focus on this CBT triangle, which involves our thoughts, our feelings, as well as our behaviors. So why do we draw it in a triangle, right? It's really to illustrate that the way we think, the way we feel, and the way we behave is very interconnected with each other. And each part of this triangle will influence the other part of the chain in this triangle. And I want to use an example to illustrate this to you. We call this the thought-feeling connection. So imagine that you are in this situation, okay, whereby you are driving and then a driver suddenly cut in front of your car in the traffic. So you're being cut off in the traffic. That's the situation. Think about what is the first automatic thought that is going to pass through your mind? What is the first thing that you think of, right? So someone might think, oh my God, this person is such a selfish jerk, right? Such a selfish person, how can they cut in front of my car? So having this thought would then lead the person to feel very angry, right? Because you feel that the person has invaded your space. So that's where the anger is coming from. However, another person in the same situation might have a different thought. They might think, oh, maybe the person is rushing for time. Maybe there's an emergency going on. And how do you think that person would feel? Most likely they might feel just neutral, or they might even feel concerned for that person. Okay, so what I'm trying to say is that two-person, right, might be in the same situation, but how they think is going to influence how they feel about the situation. Okay, so let me just give one more example to illustrate this. Okay, so now another situation that we can imagine is, let's say you have a friend, right? You are waiting for her or him to text back to you, and they're just taking too long. So it could be a partner, it could be a friend, they're just taking too long to reply your message. And your thought is that, oh, my friend's angry with me, they don't like me, leading you to have the feeling that you feel sad or you feel hurt that they take too long to text back. Maybe they don't like you, right? Person B might be in the same situation, but they might think, oh, it's okay. They're just busy. I can always call or text them back later. And your feeling might be more neutral, right? So why is it that you might think, why is it that two persons have so different thoughts about the same situation? And often these thoughts are really stemmed from our core beliefs, what we believe about ourselves as well as other people. So think about the core beliefs as almost like a sunglass. And this sunglass, right, is built from all your earlier childhood experiences, all your growing up experiences, could be in school, could be in work, and they basically frame the way that you see the world. So if I am someone who has grown up being bullied, for example, or my colleagues always ostracize me, then of course I'm going to have this frame that, I'm not likable, people don't like me, and I'm going to be more sensitive when to this kind of social situations. However, if I have the thought or the core belief that I'm likable, then I'm going to see the world in that light. Okay, so the way that we think automatically is linked to a deeper underlying thought of our core beliefs. So let's talk about the situation of falling sick, because poor health is very common in old age, right? The automatic thoughts might be, what if I don't get well? Or what if I don't die suddenly? These might be thoughts that just flash by in people's head. However, there are deeper underlying thoughts for us to kind of untangle. And another layer that is deeper from the automatic thoughts is our assumptions. We might think, oh dear, what if my wife do not have the financial means to take care of herself and our daughter, right? My family might end up losing our home, and my daughter might not go to university. And this assumption might then stem from their core beliefs of worried about being a failure as a husband or as a father. So this core belief can then cause them to feel very anxious or very depressed about the whole situation, not only just these surface level thoughts about what if I don't get well? What if I die? There's a deeper meaning as to why falling sick is so bad, right? So not a good thing that they want to happen to them. It's because they are very worried about being a failure, not being able to fulfill their duties or responsibilities as a husband and a father, for example. So in psychotherapy, we usually work through all these different steps, uncovering the thoughts that are not helpful for a person and trying to help them reframe their mind and think in a different manner. Right. So I just want to highlight some of these unhelpful thought patterns to you. Some people might only see the negative sides and they might ignore the positives. For example, they might magnify all the negative aspects of a situation and they disregard all the positive aspects. So let's say when you receive feedback, you only focus on the things that the boss say you didn't do well, or you focus on all the things you can do better but ignore all the things that you do well. Then ignoring all these positives can lead us to not see things in a more realistic manner, because we only focus on all, we magnify, we make the negative aspects bigger than what it should be. Sometimes people have this kind of thinking called all or nothing thinking. So thinking that things are only ever good or ever bad. So for example, if I deliver a presentation that is good, but then I forget one small point, and then I end up thinking that the presentation was a total failure. People probably think that I'm such a fool. People probably think that I'm not a good presenter. So sometimes people can have that all or nothing. It's like I must be perfect, or I just I suck, or I don't do it at all. Catastrophic thinking would mean thinking about the worst case scenario. For example, you're just 2 minutes late from leaving home, but you think that the whole day would be a complete disaster. Sometimes people predict the future, so they might try to think about what might happen next time. So yeah, basically trying to forecast and think about what's going to happen next. Sometimes people might mind read. They might assuming that you know what other people are thinking about and think that it's negative. So for instance, you are organizing a social event and you assume that everybody you invite will decline because they don't like you. So you are thinking and projecting that you can read people's mind and think that they say that they don't like you. Okay, or personalizing, so believing that whenever anything bad happens, you are the one to be blamed. All right, so that is just taking responsibility for something that wasn't completely your fault. So when we analyze somebody's thought processes, for instance, this one about falling sick, and their automatic thought is, what if I don't get well? What if I die suddenly? We want to try to identify which is this unhelpful thought patterns that they are displaying. So in that case that I gave just now, it will be things like catastrophic thinking. So it's just falling sick, right? But then they are already kind of blowing things out of proportion and thinking that they will die. Or it could be predicting the future as well, thinking that they know how their disease or their situation will turn out. So it's very important for us to identify these unhelpful thoughts so that we can correct them. Okay, so I like this quote by William Shakespeare, whereby in all our lives, all the situations that we face, there is really nothing really good or nothing bad, but it is our thinking that makes it so. So it is our thoughts, right, or our interpretation of an event that determines whether we perceive it as positive or negative. Just like the case that Dr. Ng shared, right? We might see another elderly going through the same exact health conditions, but they might not fall into low mood or depression. And we are thinking that it's really their interpretation, or in psychological terms, it is really our interpretation of that event that determines whether we see it as positive or negative. Okay, so just to talk about CBT, as I mentioned earlier, we usually focus a lot on identifying what are the negative thought patterns, and also how can we challenge some of these negative thoughts, right? With those unhelpful thinking styles that I told you just now. But we also spend a lot of time focusing on skills and behaviors, like what are some ways that we can help them to manage stress? What are some positive behaviors that we can implement? So don't forget that the CBT triangle, it's not just only about our thoughts and feelings, but behaviors play a big role in helping to change the way we think and the change we be in the way that we feel also. And often, this CBT is a two-way process, right? We set goals with our clients to ask them what is it that they want to achieve. What is it that they want to improve their mood, improve their anxiety, or is it that they want to go out and do more activities? So we identify this goal and then work towards that. So I also want to share some behavioral ideas with you, because not all older adults are suitable for those cognitive interventions that I talked about earlier. Okay. So behavioral activation, firstly, we need to understand how this cycle of depression is maintained. Why is it that someone might get stuck in depression? So we know that when someone feels depressed, right, they are going to feel like they have no energy, they have low mood, they have no interest to do anything. And all these symptoms are going to make them have lower their activity level also, whereby they decrease their activity level, and some of them might even neglect some of the responsibilities. So it could be don't want to do housework anymore, don't want to do cooking anymore. So there's this decrease in activity. And the more that someone not do all these activities, right, it's going to make them feel guilty about themselves because they are not contributing to the family. They feel hopeless about their future, and they feel like they are ineffective, they are not useful as a person. So how can we go about reversing this cycle of depression? I mean, notice that we cannot really change our energy levels. Yeah, maybe we can change the way that we think about the problem, but an easier way and a more straightforward way is to actually target the activity level. So in order to reverse the vicious cycle of depression, we always want to encourage people to increase their activity level so that they can feel more confident and hopeful about themselves. And when this confidence increase, right, they are going to experience improvements in the symptoms of depression, leading to more energy and more motivation and more desire to do more things. So sometimes my patients will tell me, I have no mood already, how can I go and do something, right? And the answer and the key is really to just don't wait for your mood to improve before you do something. The idea is that we have to do the task first, and then the good feelings would kind of follow afterwards. Yeah. So if the activity is not increased, then they're going to basically get stuck in that cycle. So how do I plan or schedule these activities with my patient? It could be having to visualize it for them by breaking all the bigger tasks into smaller steps. Because if we were to tell our patients to just go and let's say go to the active aging center, go and join their bingo games, or maybe go out and go NTUC, do some shopping, even such suggestions like them, they might not even be able to implement it because the task is too big. So it's better to break it down into smaller goals and write it down, plan the exact time to do it, and they can follow a more specific plan. Yeah. So we might do it in the morning, afternoon, evening manner, or if patients prefer, we might sometimes even break it down into specific timings to plan and schedule these activities. And also note that the activities have to fulfill two criteria. It cannot be just any random kinds of activities. It has to be either M, making them feel accomplished or that they have achieved something, or P, something that make them feel fun, pleasurable, and something that they enjoy. If the activities do not fulfill either the mastery part or the pleasurable part, then most likely the patients will have no interest or no motivation to engage in it, or they do not want to do it again. So we want to make sure it fulfills these two criteria. Okay, so I want to talk a bit more about anxiety. Okay, so we know that for anxiety, there's always a trigger. So in this case, I want to share with you a case that I have with regards to an older adult, a lady who has irritable bowel syndrome, IBS. So this IBS has really been causing her to have excessive anxiety. And we know that anxiety is going to cause someone to go into that fight or flight mode, leading to physical signs of symptoms, things like heart rate, heart racing, breathlessness, muscle tension, cold sweat. So these were all the symptoms that my patient was experiencing. Okay. And with all these symptoms, people with anxiety will then tend to become very hypervigilant on these symptoms, meaning that all their focus, right, will be placed inwards onto this breathlessness, this heart racing. They will start to focus inward a lot on these anxiety symptoms. Okay. So this focus, right, will then start off a chain of negative thinking that usually starts with what ifs. Okay. And for my patient, she started to think, oh no, what if I cannot find a toilet? What if I soil my pants? What if I embarrass myself in public? Right, because of the irritable bowels. So all these negative thoughts would then lead the anxiety to increase. And as I mentioned to you earlier, the thought feeling connection is very powerful. As the anxiety increases, this might cause people to engage in unhelpful behaviors. So they might then engage in avoidance. So let's say not wanting to go out. They might do a lot of checking, maybe, checking how long it takes to go out of the house, for example, so as to avoid traffic jams, and they might seek reassurance repeatedly. So for my patient, right, she started to avoid taking long buses, especially those that have to go on the highway that she cannot just get off quickly. She will not take them. She also used to like traveling, but she avoided taking planes anymore because she don't want to use the toilet in the plane. She's scared she might take too long inside. She was only about 64 years old, but she would wear diaper everywhere, and she only goes to places with clean toilets. Yeah. So the thing is that all these behaviors, right, in the short term, it was helpful for her because her anxiety reduces. But in the long term, this action, right, all these behaviors is actually telling your mind that the trigger is something to be afraid of. That's why you have to engage in all these unhelpful behaviors. So the person will then get stuck in this vicious cycle again and again. And it's very, very uncomfortable and very distressing for them. Okay, so how did I use this CBT triangle to help her? All right. So as I was mentioning, we firstly have to help her identify her thoughts. For example, what if I cannot find a toilet? What if I soil my pants? I will embarrass myself because people have to wait so long for me while I'm in the toilet. And this led her to feel anxious, embarrassed, and self-conscious. So all those negative behaviors, right, that she was doing, like, and the most embarrassing one for her was that she has to wear diapers everywhere. Okay. Now, how do we reframe our thoughts, right? So, um, instead of thinking that people are going to wait very long for me, we started to look at past experiences, and she actually told me that her friends and family are actually very understanding of her condition. They will wait for her when she's done. And she also noticed that she's able to manage the anxiety. She thinks that learning to manage her anxiety will help her to cope with her bowels as well. So when she's able to kind of reframe her thinking like that, right? Because she noticed that her bowels are affected by her anxiety, she was able to feel less anxious and more confident when she can learn skills to manage her anxiety. Okay, so some of the behaviors that we implemented was setting a timer in the toilet. So actually, right, she realized that she wasn't even spending that long in the toilet. She thought that she was spending 10 minutes in the toilet, but when we actually time it, it was only 2 or 3 minutes. So that made her think that, hey, actually, I'm not spending that long. My family can wait for me. And I taught her several relaxation techniques so that she will be able to deactivate her nervous system and calm down. And when she was able to calm down, her bowels was not that bad after all. She could also take out her diaper and then use the highway during non-peak hours. So we tried that first. And then when she's more confident, we tried the taking the public transport during peak hours. Yeah. So it's kind of this step-by-step process whereby we are able to kind of empower our patients by helping them to change their thinking and changing their behaviors, which will help them to change the way that we feel. All right. So I'm definitely noticing that I'm short on time. So sorry that this topic has like so many interesting things to share with you. But I'll just like to highlight that in terms of behavioral ways, as I was mentioning earlier on, relaxation techniques, we have to tell our patients that relaxation techniques such as breathing techniques is very, very important, because look at all this fight or flight response, right? How are we able to go back into this relaxed and resting state? The only way that we can change our own physical function is really through our breathing. That's why it's really important to implement diaphragmatic breathing that allows us to breathe deeply and slowly, for us to kind of change, for for us to deactivate our sympathetic nervous system. Yeah. Okay, so Dr. Ng, I think I don't want to like rush into the insomnia topic because I realize that the CBTI has also many different things to say. So maybe I'll address it during the questions, or I can talk about it during my next talk
Thank you,
in Zoom. Will
Celia.
that be okay?
Yeah, actually, CBTI is quite a natural transition into maybe if you could like give a very short introduction. What does
Sure.
CBTI entail? How do you
Mm,
apply CBT on people with insomnia?
sure. Let me just move on to the slides on that
Yeah,
in that case. Yeah. So I wanted to talk about sleep and aging. Okay.
this
So
is very interesting. Maybe we should do it again the
yeah,
next
I really
time.
think it warrants maybe it warrants a
Because
topic on
sleep
its own.
disorder is very common and we cannot always
Right.
prescribe. Yeah.
Yes. So let me just quickly talk about the cognitive and the behavioral part of CBT for insomnia, okay? So the thing is, we also want to challenge negative thoughts about sleep, because people can have very negative thinking about their sleep that cause them to be more worried, more anxious, and then they cannot fall asleep because of these worries. But something unique about CBTI is also implementing sleep hygiene habits. So that means telling people some what are the good habits for sleeping, and
Mm.
also managing their sleep time and wake time.
Mm.
Okay, so yeah, some of the good sleeping habits include going to bed at a fixed time, sleep time and wake time. Okay, having a very consistent bedtime routine. That means maybe you can take a warm shower first, listen to some music, and then signal your body for sleep, winding down. So these are more the the behavioral
Yeah,
techniques for
yeah.
sleep. Okay, so optimizing the sleep environment, making sure it's cool and dark, using blackout curtains, making sure the temperature is good, for example. The most important thing is do not toss and turn. So
Mm.
implementing a 20-minute rule, whereby if you cannot sleep after 20, this applies to ourselves also lah. You know, if we cannot fall asleep, right, after 20 minutes, some people will get up their phone and then start scrolling, but this will actually activate their brain even more. So we want to reduce that. Go outside, do something really boring, and then come back and sleep again and dim your lights. Okay, so I had a case as well, but let me just
We may
move.
not have, yeah, maybe
Yeah.
just the CBTI. Yeah.
Yeah, I wanted to talk about their thought challenging. So my patient, right, she was really obsessed with wanting to get 7 to 8 hours of sleep. She was thinking that if I don't get this amount of sleep, my day would be ruined. And if my sleep is ruined, I cannot function during the day and I won't be well rested. So I will be irritable the next day. Or it's already 4 a.m. She's watching the clock all the time. It's already 4 a.m. and I'm still awake. There's not much time for sleep. So how can we challenge those thinking, right?
Mm.
So I helped her to kind of reframe her mind that, hey, she already slept 5 hours, and that's really enough to complete her very minimal day of activity. She only had to cook for her husband. So she really don't need 7 to 8 hours at all. And if I don't sleep well, then she might be more likely to sleep well tonight, because there is a sleep debt that is being
Mm.
accumulated. We also talked about what is the worst thing that can happen. Yeah, okay, if you don't sleep well, maybe the worst thing is you might feel some irritability, but that's it. That's all you have to deal with. And if she has already gotten 5 hours of sleep, that's enough. And also her sleep will continue to improve as she learn more of those behavioral techniques, like the sleep hygiene techniques that I mentioned just now. So when she was able to reframe her mind and also implement the good sleep hygiene techniques, then her insomnia really improved. And yeah, she was very worried of becoming over reliant on medications.
Yeah.
So we were able to help her with this. Yeah.
Thank you, Zelia. I
Thank
hope we
you. Yeah.
can come back to insomnia again in June. Well,
Yes, I
for the
think I'll do that.
audience,
Yeah.
in June we are going into a topic which is also an area of specialty for Miss Zelia
Yes.
on cognitive therapy, cognitive training for
Cognitive
people.
health. Yeah.
Yeah, for people with dementia, which is something that as doctors, when it comes to Alzheimer's disease dementia, we sometimes we feel quite helpless because medications doesn't quite cure it, but it does improve on some of the symptoms and delay the progress. But still, cognitive training and cognitive health is something that we could consider and perhaps consult a psychologist or refer for psychologists to help our patients with Alzheimer's disease. So that will be coming up in June. And we will discuss with Zelia if we could also incorporate the teaching on insomnia because it's really common. Yeah.
Yes. So
Yeah.
sorry for overrunning
No
today.
problem. It's very
Um,
rich. Yeah. What
yes,
you
but
just shared.
I just wanted to share with everyone that I will share this deck of slides on my website, so
Ah,
you can just go there and download it and also read it on your own. And then of course I will explain it more in June if we revisit
yeah.
this topic. Yeah.
Thank you very
Yeah.
much,
Thank
Celia.
you. Thank you.
So
So
we have
yeah.
got 4 questions.
Okay. Sure.
Yeah, maybe Zelia you could unshare, then we could.
Okay. Yeah.
Yeah. Okay. So well, if you can answer them, the first one
Okay.
is can a person be born with high tendency for low mood and easily get depressed?
Yes, so we were talking about the genetic
Yeah.
disposition of depression and anxiety, and there are many studies, especially twin studies, that shows that yes, if the mother or father lah has depression, then there is a likelihood for there's that gene that might be passed down to the offspring.
Mm. Yeah.
However, the gene might only be activated if there are also chronic life stresses going on. So
Mm.
let's say you might have the gene for it, but if you have everything smooth sailing, or you have very good coping strategies, that part of the genetic component might not be activated. So it is a combination of the biological disposition and the environmental situation. Mm.
Thank you so much, Celia. The second question is, I think it was posed when you were talking about CBT. So
Yeah.
are all these interventions, they sound very intentional and planned. So how do we get a person to feel motivated enough to start the first step? I think it was related to the vicious cycle of depression, to increase the level of activities. So how do you motivate a person to even increase the level of activity?
Yes, so because if they are already depressed, then of course the low levels of depression is going to be very common. So in terms of increasing someone's motivation, there's also another technique called motivational interviewing that we can use to try to encourage them to or rather determine what stage of change this person wants to be at. Because some people are depressed and they don't want to improve, right?
Mm.
Then that will be very like they might be more treatment resistant in that
Yeah.
sense because they themselves don't have the willpower or the desire to improve. That is very different from someone who comes to us and say, I know I'm depressed, but I'm tired of this, I want to get out of it. Yeah.
Mm.
So we need to determine what their motivation levels is at the beginning.
Yeah.
However, we can also try to implement some experiments. So if the person don't buy in and they say, no lah, this is not going to help me, then we will still encourage to just give it a try, just go and do the activity, go and let's say exercise, for example.
Yeah.
Do your exercise for 15 minutes and then you come back and tell me how you feel afterwards. And
Mm.
if this activity, right, fulfills the M and the P I was talking about, it makes them feel accomplished and it is pleasurable to them, usually they will want to continue it.
Mm.
Mm.
Thank you. Okay, Dr. Robert Ong asked about seniors. This is, I think, a common issue in social prescribing. Low mood, is it better for them to receive emotional counseling or active aging center activities or both?
Mm, I would say it depends on the severity of the low mood. because depression is not just one type. It exists over a continuum with different levels of severity. So if their low mood is still like a manageable, then I definitely would say try the activities first,
Yeah.
because the social stimulation, just distracting them from their worries and their thoughts, can in itself be very helpful already.
Yeah.
But if you notice that the activities, you've really tried to persuade them but they still don't want to join, then they probably need further counseling or therapy to motivate them or reframe their thinking about their current situation.
Mhm.
Yeah.
Thank you. The last question, for a layperson not trained as a psychologist or psychotherapist, if we try any of these, such as CBT, what caution do we need to take? Can you share with us?
Yeah, that's a very nice question. So, um, so the thing is, all these CBT strategies, right? They can be learned by anyone, because we are also teaching our patients these strategies to empower them to use it on themselves.
Yeah.
Right. So I think maybe just a caution is just when reframing the person's mind, because like I said, the thoughts can be very powerful, right? So we want to make sure that we are helping them to reframe into a a mindset that is going to be like beneficial and helpful for them. Otherwise, the behavioral strategies like the relaxation techniques, the behavior activation can be implemented by anyone.
Thank
So
you
I
so
would,
much. Yeah.
yeah, I would say just be sensitive to their thoughts, because some people can some people can be more sensitive about their way of thinking.
It reminds me of the example that you gave, that the lady who couldn't sleep for 7 to 8 hours and she's very concerned about it. So as doctors and nurses, we always tell people you should sleep at least 8 hours. I think
Yeah,
can
yeah.
be triggering, yeah.
Yes, yes. If I
Yeah.
mean, they might also tell me, oh, my doctor say I need to sleep for 8 hours, so how can I only sleep for 5 hours? So
Yeah.
that might be, yeah, a stress also.
So as clinicians, we have to be aware that we wield a certain power to trigger emotion. So we have to be really sensitive about, especially patients with history of mood disorder. Okay, so
That's
with
right. Yeah.
that, we have finished a very interesting and very enlightening talk from Zalia, especially when she shared about CBT for anxiety and the vicious cycle of depression, that we need to really prescribe activities. But the problem is that a lot of seniors, when they really need it, they won't go for it. And thanks to one of the person who asked about motivations, and also the question about whether we can apply it, and Zalia have confirmed that even lay people are taught, patients themselves are taught to be empowered. So surely we can do it, but we just have to be a bit more aware of the power of our words. Because as doctors and nurses, we tend to be
Yeah.
very prescriptive. These are the standards. And then if you live with the standard, it's very hard to fall asleep. So with that, we'd like to call it a day. And thank you for your participation. And please give us the feedback and you get your CME points. And next month, we are going to have a sharing on as our speech therapist will be sharing about swallowing disorder, how to assess and how to prescribe for that. And also I'll be covering with her together on the topic. So thank you, Zalia, and thanks to all the participants. And this will be posted on our YouTube channel. Yeah. Bye-bye.
Bye.
Bye-bye. Thanks.